Okay, thank you, sir. So I'll be continuing from there. So this patient with aortic stenosis can have syncope, and this syncope could be exertional or at rest. And the exertional syncope can be during exercise or even post-exercise. And like we mentioned earlier, can be as a result of reduced cerebral
I think
perfusion.
we can start recording, please.
Okay, please can you hear me?
It's showing that you are recording. Are you not? Chief Kwaki is showing that you are recording.
I've started. We can
It went off earlier, so yeah.
Continue.
All right, continue. Continue,
Okay.
Alex. Welcome.
Thank you, sir. So angina is usually very common in them, but the other thing they can have is syncope, and syncope can be exertional or at rest. So the exertional syncope can be while the exercise is on or even post-exercise. And the reasons for this could be one, there's reduced cerebral perfusion, because we know that demand increases in exercise, but the stroke volume is almost fixed or unable to match the demand. So you have reduced cerebral perfusion from decreased systolic blood pressure and fixed forward stroke volume despite systemic vasodilatation during exercise and post-exercise. Another reason why they can have exertional syncope is as a result of either arrhythmias from the atria or ventricle. And then there can be malfunction of the bioreceptor mechanism in aortic stenosis as well. So they can have syncope even at rest as a result of either transient atrial fibrillation or transient atrioventricular block. GI bleeding may develop in severe aortic stenosis, and this is called Hyde syndrome, associated with angiodysplasia, frequently affecting the lung, and arises from shear stress-induced platelet aggregation with a reduction in high molecular weight multimass of von Willebrand factor. And this is said to correlate with severity of aortic stenosis and is usually corrected by aortic valve replacement. Patients may present with manifestations of infective endocarditis, particularly if they are young and they have the bicuspid valve etiology. And they can also have strokes, TIA, and calcific aortic stenosis rarely may cause embolization of calcium to the heart and kidneys. So in terms of their physical examination, the typical pulse that they have, the carotid pulse they have in severe aortic stenosis is called the pulsus parvus erectus, and it refers to a slow rising, late peaking, low amplitude carotid pulse, and it's also described as delayed plateaued peak with decreased amplitude and gradual downslope. When it is present, it is said to be specific for severe aortic stenosis. However, if there's coexisting aortic regurgitation or in the elderly who already have stiffened carotids and hypertension, it may be absent. So it is said generally that normal carotid impulse does not exclude severe aortic stenosis. So other things we can find is the carotid shorter or the palpable trill, which is a radiation of the murmur to the carotid arteries in severe aortic stenosis. And they can have some pulsus alternans as well because of the left ventricular systolic dysfunction. So the late peaking ejection systolic, that's the crescendo murmur, is heard best at the base of the heart, and it radiates the carotids. So prominent high frequency components may radiate to the apex, and that is what is known as the Galavadin phenomenon. And because it can radiate to the apex, this can be mistaken for the murmur of mitral regurgitation. Another thing they have commonly is the splitting of the S2. And S2 may be single in severe aortic stenosis. And then calcification and immobility of the aortic valve may make A2 inaudible, soft, or absent. Closure of the pulmonic valve, the P2, is buried in prolonged aortic ejection murmur, or prolongation of left ventricular systole makes A2 coincide with P2. Okay, so we now have a reverse or a paradoxical split of A2. But when there's a late closure of the aortic valve, it will cause a delayed A2. Also, we can hear a P2, which may be accentuated in the presence of secondary pulmonary hypertension. So in terms of the dynamics of auscultation or the murmur of valvular aortic stenosis is augmented by squatting or anything that would increase stroke volume, while whatever will reduce stroke volume would reduce the intensity of the murmur. I'm not sure if this is very clear. And please, can you see my cursor? Hello?
Yes, Pope, we can see
Thank
your
you.
cursor.
Okay, thank you. So if we look here, this is S1. And from this point, this is the point where we have the crescendo, decrescendo murmur, and then the components of the second heart sound, A2, P2. So S1 is normal, usually in them. S1 is normal or soft. So now this diagram here shows for mild, moderate, and then when we have severe aortic stenosis. So in mild aortic stenosis, S2 is normal. So S2 is normal in mild aortic stenosis. You can see that the A2 component precedes the P2 component. Okay. While in moderate aortic stenosis, you have S2 becomes single. Why S2 becomes single is that the closure of the AV is delayed until it coincides with the closure of the pulmonary valve. Okay, so the closure of AV is delayed until it coincides with pulmonary valve, the PV. That is why you have the a single stroke. If you look at it here, and you don't have like the A2, P2 that you can have in the mild form. And then the other thing we would also notice, okay, let me just go down first to the severe and I'll come back. While in severe aortic stenosis, there's paradoxical splitting of A2 after P2. Okay, so what normally happens in aortic stenosis is that in the mild form, the murmur, the crescendo, decrescendo murmur begins just after the first heart sound, and then it ends before the components of the second heart sound in the mild case. As the intensity worsens, the murmur comes after the first heart sound. You have the crescendo, decrescendo murmur, and then it gets closer to the second heart sound. But in this case, because of the delayed closure of the AV, it coincides with the closure of the PV. So what you have is that you just have one or a single sound, which is the A2. And then in the setting of severe aortic stenosis, what we'll have is that, yes, the murmur begins after the first heart sound. It's a crescendo, decrescendo murmur, but it's for a longer duration. And then we have that there's now a reversal or a splitting. We now have the P2 coming just before the A2. This is important to note as we'll go on, speak more on this. So what are the findings on echocardiography? Echocardiography is very important, we know, because it can help to define the valve anatomy, including the cause of the aortic stenosis. For example, if it's as a result of decalcification, we see that. And then looking at the anatomy of the valve too, if they are bicuspid on echocardiography, that can be seen. And then echocardiography can also help us find out the, on Doppler, we will know what the transaortic jet velocity is, and also the transaortic pressure gradient, which we can now use to calculate in the Bernoulli's equation. And then we look at the aortic valve area using the continuity equation. And then it also helps us, echocardiography helps us in the evaluation of left ventricular geometry and gives an idea of what systolic function is. When there's left ventricular dysfunction, the dobutamine echo can be done, especially when there's low cardiac output, because occasionally we can have pseudo-severe aortic stenosis. One of the ways to differentiate that from the real severe aortic stenosis is to do this stress test, especially when there's left ventricular dysfunction. And then echocardiography can also help us see if there are coexisting valvular lesions like aortic regurgitation or mitral regurgitation. So this table shows severity of aortic stenosis according to the valve area, the consequent gradient across the valve, and then the echo Doppler jet velocity. So divided into mild, moderate, and severe. For mild, the area will be greater than 1.5, the gradient less than 25 millimeter mercury, and Doppler jet velocity usually less than 3. And then for moderate, we have the valve area between 1 and 1.5. Gradients between 25 to 40. And then the Doppler jet velocity between 3 and 4. When aortic stenosis is severe, the area will be less than 1. The gradient, the pressure gradient will be more than 40. And then we have the jet velocity also more than 4. The American Heart Association gave some definition about aortic valve disease, and this is also replicated for most valve diseases, stage A, B, C, and D, where stage A is actually at risk of aortic stenosis, and the valve anatomy that at risk include those with bicuspid aortic valve or other congenital valve abnormality. And then when there's aortic valve sclerosis. So when we do echo and see aortic valve sclerosis, it may not be aortic stenosis yet, but it puts that individual at risk. And then if the velocity is less than 2 meters per second, and then there's no hemodynamic consequence or there's no symptom, that individual is at risk. Stage B is those who are is called progressive aortic stenosis. In this stage, there's mild to moderate leaflet calcification of the bicuspid with some reduction in systolic motion or rheumatic valve changes. So in this one, you have the VMAP 0.9, and then the pressure is really less than 9. So the hemodynamic consequence in the progressive stage is that you can have early dysfunction and may be present. And then in this progressive stage, and then such patients may not have any symptoms. Then in stage C, we will talk. So for the asymptomatic severe aortic stenosis, for C1, aortic stenosis, the severe leaflet calcification or congenital stenosis. In this case, the aortic Vmax, that's the velocity, is more than 4 meters per second. Then the gradient more than 40. The aortic valve area is well, or the aortic valve area index less than 0.6. And then in very severe aortic stenosis, we have the velocity more than 5 more than or equal to 5 meters per second, and then pressure greater than 60 millimeter mercury. So these patients at this stage already have some left ventricular diastolic dysfunction. They have mild left ventricular hypertrophy, and ejection fraction might still be normal. Okay, they might not have any symptom, and exercise test testing is reasonable to confirm symptoms in this stage. Then for the C2, they are asymptomatic severe aortic stenosis, but in this case, they now have left ventricular dysfunction. So the ejection fraction will be less than 50, and then the other parameters is like what we have in the C1. While in D1, D2, D3, this is now the case of severe aortic stenosis. For D1, they are symptomatic severe high gradient, while D2, they are symptomatic severe low gradient, low flow, low gradient. And then D3, they are symptomatic severe low gradient aortic stenosis with normal left ventricular ejection fraction or paradoxical low flow severe AS. And then the findings or the hemodynamic consequences, and then the outcome will be as seen. So we'll see that most of the patients that begin to have symptoms that have mean survival ranges would normally come from when they have severe, aortic stenosis, where we see things like angina, syncope, okay, and then heart failure ultimately. So the management could be medical, surgical, and then balloon valvuloplasty. In the medical management, if they already have heart failure, we like to treat as such. Then in the presence of pulmonary hypertension too, that should be managed. The medical treatment is just actually to control other comorbidities or the symptoms the patients will have. So, but there are interventional things or surgery that help to now correct the abnormality found in the valve. So one is doing a balloon valvuloplasty, which has very modest hemodynamic effect. It's not the definitive management, but helps to buy some time. It can provide short-term improvement in survival and quality of life, but the benefits are usually not sustained and is a reasonable bridge to definitive treatment with aortic valve replacement in unstable patients. In unstable patients, palliative procedure in patients who are not candidates for aortic valve repair, like those who are very elderly, who are frail, who have many other comorbidities. So this balloon valvuloplasty can be done in them, just short-term improvement of their symptoms and then quality of life. But for the aortic valve replacement now, a surgical aortic valve replacement, the SAVA or the TAVA, which is the transcatheter aortic valve replacement or intervention, whether called TAVA or TAVI, can be done. Just to refresh our minds again on the levels of evidence and the classes of recommendation. The class A is when you have data derived from multiple randomized clinical trials. So it's high up there. And the highest level of evidence is around, multiple randomized clinical trials. So while in level B, we're talking of data that is derived from a single randomized trial or from lab studies, while at level C has to do with consensus opinion. And in class 1, we're talking about the class of recommendation, the condition for which there's evidence, general agreement that a given procedure or treatment is. For class 2, we're talking about conditions for which there's conflicting divergence of opinion about the usefulness. And 2 is divided into 2A and 2B. 2A, favor of its usefulness, while in 2B, the usefulness or efficacy is less well. The conditions for which there is evidence your treatment is not useful or effective or okay. But this slide now, it's just how to move in terms of the management. First is that to look out that there's already or reduced opening at systole, because that's when this aortic valve opens at systole. So is there abnormal aortic valve or reduced opening at systole? You have to look out first whether they see. So if there are aortic stenosis symptoms, then you look at the velocity jet. If it is greater than 4 meters per second, and the symptoms are due to aortic stenosis, you go straight for aortic valve replacement. This is a class 1 recommendation. However, if you have symptoms, the symptoms in the patient, they are due to aortic stenosis, and then the jet velocity is less than 4, and then you look out for the ejection fraction. If the ejection fraction is less than 50, then you have to do the dobutamine stress echo. And then if the dobutamine stress echo, you still have the peak gradient, the peak and jet velocity as greater than or equal to 4 meters per second, or you have the mean gradient greater than 40 millimeter mercury, and aortic valve area is less than 1.0 centimeter square at any flow rate, then the definitive treatment is to go for aortic valve replacement. However, if you have ejection fraction less than 50, and then the aortic valve area index is still less than or equal to 0.6.
Please use your pointer so you can follow.
Okay, so thank you. So the division is whether the patient have aortic stenosis symptom or not. So if they have symptoms from aortic stenosis, which could either be angina, syncope, okay, or they are even in failure, or they have other things, fatigue, and then we've already established that there's an abnormal aortic valve, or there's reduced opening during systole. So the next thing to look out for is to ask, what is the jet velocity? Is the jet velocity more than 4, which is the cutoff for severe aortic stenosis? So if the jet velocity, if the jet velocity is greater than or equal to 4, the guideline says you go straight for aortic valve replacement. And this is already class 1 level of recommendation. However, the patient has the symptoms due to aortic stenosis, and then the jet velocity is less than 4. So you now go ahead to look out for the ejection fraction. Is the ejection fraction more than 50 or less than 50? If ejection fraction is less, you go ahead to do a dobutamine stress. And then if with the dobutamine stress echo, if you at 4 meters per second, or you jet velocity or the mean gradient will go together. So by doing the dobutamine, jet velocity is more than 4, or the mean gradient is greater than valve area is less than 1. These are descriptions that are stated as severe. So you go straight again for aortic valve replacement, but this is level 2A evidence and recommendation. So if the ejection fraction is more than 50, you look at the aortic valve area index. If the aortic valve area index is less than or equal to 0.6, okay, or the stroke volume index is less than 35 mils per meter square, you still go on, okay, to do a replacement. Then for those that the symptoms are, they don't have aortic stenosis symptoms, you still look at the pressure gradient. If it is more than 5 and they have low surgical risk, you do a valve replacement. However, if the jet velocity is more than 4, and then you still come back to the ejection fraction. Is it more than or less than 50? If the ejection fraction is less than 50, you still go on to the valve replacement. It's class 1 evidence. If it is more than 50, then and there's decreased, reduced exercise test tolerance, decreased blood pressure, or decreased capacity, you still go ahead and do a valve replacement. Okay. On all this to their surgical risk. Okay. The risk is low surgically. Aortic valve replacement, which is the SAV. However, it's intermediate. You can have later on and says on which is preferred. Surgical risk, straightforward, you go intervention in there. Like aortic stenosis, from the kind of from atherosclerotic lesions, you can have some differentials. Example from the kind of crescendo decrescendo normal, mitral tricuspid regurgitations can look like 8. Hyperdynamic state, for example, when we have hypertrophic cardiomyopathy, that can also look like a closed differential. Then in the presence of coronary artery disease, if there's angina, we think about other atherosclerotic diseases as well. Then the other things to think about in terms of the diagnosis, differential diagnosis, is to look at the lesions that we have. Aortic stenosis is a valvular lesion, but occasionally you can have a supravalvular obstruction or a subvalvular obstruction. Okay. For example, in a supravalvular obstruction, you might have a congenital fibrous diaphragm that is found above the aortic valve. And this can be associated with mental retardation and hypercalcemia. This is what is known as the Williams syndrome. And then for subvalvular aortic stenosis, in this case, there's congenital fibrous ridge or diaphragm that is located below, just immediately below the aortic valve. So all these two are close differentials for aortic stenosis. Then hypertrophic cardiomyopathy too is a close differential because you have septal muscle hypertrophy that will be obstructing left ventricular outflow. So there are recommendations for data recording and measurement of aortic stenosis quantification. If we look here, it tells us there are different aspects talking about the data elements, how the recording should be done, and how the measurement should actually be done. And these are standards to be able to help us to arrive at a good diagnosis. So in this plot view here, we can see that this is measuring the left ventricular outflow tract diameter. Okay, so and the recording should be done in 2D parasternal long axis view and then zoomed in. Okay, so that you adjust for the gain to optimize blood and tissue interface. Right, so the measurement should be done from inner edge to inner edge, like we say always, leading edge to leading edge, and it should be done at mid-systole. Okay, and then we can see that it should be parallel and adjacent to the aortic valve or at the site of velocity measurement. Okay, another thing to look out for is when we are doing the recording, pulse wave recording. Okay, so if we're looking at the velocity now of the LVOT velocity, it's at apical 5 view. Okay, apical 5 chamber view, and then we use the pulse wave Doppler, okay? And then the sample volume is positioned just on LV side of the valve and moved carefully into the LVOT if required to obtain laminar flow curve. The laminar flow curve is important, okay? In the velocity baseline and scale adjusted to maximize the size of the velocity curve. So how is the measurement to be done? Maximum velocity from peak to dense velocity curve. Okay, measured here. Then the VTI is traced from the modal velocity. So as well as looking at the aortic stenosis jet velocity, for the jet velocity, we are looking at using continuous wave Doppler. We use continuous wave Doppler for the jet velocity using a dedicated transducer. So multiple acoustic window can be done in this case. You can do an apical, parasternal, and then right parasternal. So multiple acoustic windows are advocated, okay? And then you decrease the gain, you increase the wall filter, you adjust the baseline and the curve. All these recommendation on how the recording should be done, and then how the measurement should be done. Okay, it should be maximum velocity at peak, maximum velocity at the peak. Yeah. Okay. And then avoid the noise and find linear signals. BTI traced from outer edge of dense signal. All this is just to give us a guide as to how the aortic stenosis jet velocity can be obtained using the continuous wave and Doppler. Then for the anatomy of the valve, it's also very important. You look at it on parasternal long and then short axis views, and advisable to zoom the image so that we can identify the number of cups in systole, and then if there are raphes or septae or separations, and then it will help us also know whether we have a unicuspid, bicuspid, quadricuspid, or sometimes even if we have fenestrations, can help to know. Then in these views, would also be able to assess the mobility of the cups and then the fusion if there are of the commissures. Then we'll also be able to see when there's some valvular calcification. So this will now help us to have a way to assess the severity based on the peak velocity, the mean gradient, aortic valve area, the index of the area. We can also use the velocity ratio as well. So for mild, moderate, and severe, we've touched on this earlier. So for mild, we would have that the peak velocity between 2.6 and 2.9, the gradient to be less than 20, the valve area greater than 1.5, and when we do an index, it's greater than 0.85. While for the moderate, we have peak velocity 3.0 to 4.0, gradient 20 to 40, and then the area is just in between 1.0, 1.5. And then for severe, the peak velocity will be greater than or equal to 4. The mean gradient greater than 40, greater than or equal to 40. So then the aortic valve area less than 1, and we can index of less than 0.6 and the ratio of 0.25. Okay. So other ways to look at the aortic stenosis jet's velocity is also by direct measurement, and the cutoff for severe is 4.0. Okay, we can use the formula to calculate for the mean gradient, the modified Bernoulli's criteria, and the cutoff is also 40. From 40 and above is already severe. Okay, and then the concept is just about pressure gradient calculation from velocity using the Bernoulli equation. So still on the aortic valve area, we can use the continuity equation valve area. This has been validated and shown to be of high value in looking at the aortic valve area. So the cutoff is usually 1.0, less than this is severe, and then 1 to 1.5 mild. moderate, and then above 1.5 is mild. So but from the continuity equation, we'll be able to measure the effective orifice area, the EOA, effective orifice area. And then this can be done in nearly all patients. Okay, so this also is just a guide on using the simplified continuity equation. The cutoff for severe is still 1.0. Okay, then the velocity ratio, like we saw earlier in the slide that compared the mild, moderate, and severe, the velocity ratio is still 0.2, and it's just the difference or the change, the ratio of the velocity of the left ventricular outflow tract and the valve area. Okay, so other ways to look at this is planimetry of the aortic valve using transthoracic echocardiography and then 3D echo. So even on planimetry, the cutoff for severe is still 1.0. Okay, and the concept is to look at the aortic valve area measured by either 2D or 3D. So, and the advantage is that it is useful if Doppler measurements are unavailable. Okay, so there can be some sources of error when we are trying to use either the continuity equation or trying to measure all of this area. Occasionally, we can have some errors. For example, there can be misalignment of the ultrasound beam with the aortic stenotic jets, and this will lead to an underestimation of the jet velocity. Okay, and even greater underestimation of the pressure. So that is a squared relationship, because when we underestimate the jet velocity, try to calculate, also have effect on the gradient and reduce. So in terms of the aortic valve area now, you know, we can check in different views, and this can lead to variability in each of the measurements that we can have. Then the aortic stenosis jet and LVOT velocity measurements can be low, intra, and you can have inter-observer variability. So all these are just, you know, possible sources of errors that we can have. In time, there can be underestimation of the stroke volume and even the aortic valve area. Okay, there are several of them. And then, like we said earlier on, the aortic valve area by continuity equation has been well validated in both clinical and experimental studies, and has been reported as a valuable parameter for prediction of clinical outcome and for clinical decision making. Okay, there are some special groups where you can have some discordant findings. Okay, so because we know that the velocity and gradients are flow dependent, so occasionally when you have measurement of velocity and gradient of the valve area discordant, meaning that we can have, let's say we have a valve area. The valve area can be greater than 1.0 cm square, and then the peak velocity is also greater than 4, and then you have the mean gradient maybe greater than 40. Okay, that tells you that that is high flow, high transvalvular flow. It's high transvalvular flow. Okay, but when you are having peak velocities, greater than 4, mean gradients greater than 40, you know, one would have expected that the valve area should be maybe less than 1, or to have a severe aortic stenosis. So those kind of discordant findings can be seen. You know, sometimes you check the valve area, looks normal, then you do your velocity, look at the velocity and the gradient. Like these two, this velocity here and gradient, look at what we would consider for severe aortic stenosis, but this valve area does not go for it. So with this kind of gradient, we know that there's high transvalvular flow. So in this type of setting, we now have to look at other things. For example, is there a concomitant aortic regurgitation? Are there shunts? Other conditions that can cause hyperdynamic states like fever, anemia, hyperthyroidism. Okay. And then if the person has an AV fistula, that will also increase the volume in that area. So that means that the area is actually fine, but what you have is that you're having a high transvalvular flow. Okay. At other times, you can see, excuse me, you can see that the valve area is small, it's less than 1. And then in this case, you now have the peak velocity less than 4, and then the mean gradient less than 40. Okay, so you see that there are measurement errors for the components. Okay, so because in this case now, everything, is looking like fine. And then this can lead to an underestimation of the LVOT area. Okay, so the current cutoffs for valve area and velocity gradient, they are not consistent. Sometimes there are some differences. When you check, you recheck, you keep having different values. Okay, so to generate a mean gradient of 40 millimeter mercury at normal flow rate, the valve must be closer to 0.8 than to 1.0. Okay, so if you're having this type of discordance, so to generate a gradient of 40 millimeter mercury at normal flow rate, so the valve area must be closer to 0.8 and than to 1. It should be smaller, less than 1. Okay, and then this discrepancy seems to affect especially patients with a small LVOT diameter. Small stature of the patient may be another reason for the finding of a small valve area and low gradients. So if you have a small stature person, you can have small area as well as low gradients. So in aortic stenosis, we can have low flow, low gradients with reduced ejection fraction. So if the left ventricular systolic dysfunction with reduced stroke volume coexists with severe aortic stenosis, the aortic stenosis velocity, the gradient may be low despite the area, because we know that the force of contraction or the pressure across the valve also plays a key role. Okay, so it's possible to have severe aortic stenosis. One can have severe aortic stenosis, but it may be low flow, maybe low gradient because of the left ventricular systolic dysfunction, which can coexist. Okay, so the effective aortic valve area will be less than 1. And then the mean aortic transvalvular pressure gradient less than 40, ejection fraction less than 50, with the stroke volume index, which gives us an idea of the minutes, the beat by beat ejection will be less than 35 mils per second. In another setting, we can have severe aortic stenosis causing left ventricular dysfunction. And this is the true severe aortic stenosis, because as we have the narrowing, the pressure continues to increase the left ventricle, which now results in hypertrophy. But as this pressure increases and the heart being unable to meet up, it eventually fails. So we can have severe aortic stenosis causing left ventricular diastolic dysfunction. This is seen as the true aortic stenosis. So aortic valve replacement will relieve the afterload and may also allow the left ventricular ejection fraction to increase back to normal. So what if we have pseudo severe aortic stenosis and true aortic stenosis? How are we going to know the difference? So one way to know the difference is to use the low dose and the dobutamine stress echo. So in doing this, which I will show in the next slide. So by the time we administer this, there'll be an increase in effective aortic valve area, which will lead to a final valve area that is greater than 1.0. And that will suggest that stenosis is not severe. Okay. Then if we have severe stenosis is suggested by the aortic stenosis jet velocity more than 4, mean gradient between 30 and 40, and then the area does not exceed 1.0 cm squared at any flow. Okay, so, and then absence of contractile reserve, that's failure to increase the stroke volume by more than 20%, is a predictor of high surgical mortality and poor long-term outcome among valve replacement. Although valve replacement may improve left ventricular function and outcome, even in this subgroup. So if we have patients that do not experience an increase in the systolic volume, in the stroke volume by at least 20%, so that is a predictor that mortality will be high, surgical outcome will be poor. So this kind of patients can benefit from valve replacement. So in the low dose dobutamine echo, this is the protocol for it. You start dobutamine dose at 2.5 to 5 microgram per kg per minute, and then you increase it stepwisely every 3 to 5 minutes until you get to maximum dose. Okay, so that you stop the infusion when you have reached the maximum dose of 20 microgram per kg per minute, or when you have a positive result already, and then, or when the heart rate rises about 10 to 20 beats per minute over the baseline, or it exceeds 100 beats per minute, and then, or when there are symptoms of blood pressure falls, or you have significant arrhythmias. These are reasons to discontinue the dobutamine stress test. So when do we say we have a positive low-dose dobutamine stress test? We say we have a positive result when there's an increase in the effective aortic valve area, okay, to a final valve area that is greater than 1 cm squared. And that suggests that stenosis is not severe, okay? Severe stenosis is suggested by an aortic stenotic jet velocity greater than 4.0, greater than or equal to, or a mean gradient of greater than 30 to 40, provided that the area does not exceed, as the area is still less than 1. And then we have said this earlier on that when there's absence of contractile reserve, which means that there's failure to increase the stroke volume by more than 20%, this is a predictor of high surgical mortality, okay, and outcome. Although the replacement, valve replacement may improve left ventricular function and outcome in this group of patients. Okay, so I'm not sure if we're seeing this clearly, but this, what this is about is that from your echocardiography, when you look at the valve morphology, from the valve morphology and echo, and then it is suspicious of aortic stenosis, then you access the velocity gradient. That's the first thing to do. So there are 7 steps. First, you look at the velocity gradient. Then you look at the valve area. Okay. So then you try to ensure that you exclude measurement errors that can cause gradient flow, the valve underestimation. And then we look at the stroke volume index. Then step 5 is to access the left ventricular ejection fraction. And then you look at the dobutamine echo to be able to differentiate whether you have a pseudo or a severe, and eventually a calcium score by CT. This will help us if we're looking at degenerative calcific form of deposition and aortic stenosis. So in the first step, when we look at the gradient, we look at, is it high or low gradient? We'll be able to see, and then the velocity, if it's low, to be less than 4, and pressure will be less than 40. If it is high, to be the opposite. Then we look at the aortic valve area in terms of the size. Is it less than 1 or greater than 1? If it is greater than 1, already we're dealing with something less than severe. So we go on, if we know it is less than 1, we want to now know whether there's a measurement error. And then we look at the stroke volume index. And then if the stroke volume index is less than 35, that is low flow. If it's greater than 35, that is high flow. So once we have a stroke volume index greater than 35 mils per meter square, it means that severe aortic stenosis is very unlikely. And then we'll now go on to look at assessing the left ventricular ejection fraction to see whether it is less than or greater than 50. If it's less than 50, so you have poor myocardial contractility, you still want to be sure, is this as a result of a flow reserve deficiency or there's no such issue with flow reserve? You also want to rule out, am I dealing with something like a pseudo severe aortic stenosis or a true aortic stenosis? Okay, so if high flow status has been excluded, for example, if we have this gradient 40 more than this and greater than 40, we look out for things like anemia, hyperthyroidism, we have to exclude all that. Okay. So if they are not there, or if they are there and then you still have severe high gradients, normal flow. So the algorithm can just be followed down that way. Then this is an algorithm for multimodality imaging assessment of patients with discordant grading of aortic stenosis at Doppler echocardiography. Okay, so you have discordant grading, low gradients, as at when the transthoracic echo was done, and low gradients, but we have the area being less than 1, and the aortic valve area index 0.6, the gradient less than 40. Okay, so one would have expected that the gradient to be more. So this is discordant. Okay, small area, low gradient. So the next thing to do is to confirm the accuracy of this. And so you have to look at the views that we talked about, the guidelines on how they should be taken. Then you collaborate the aortic valve area by hybrid multi-detector CT Doppler imaging. Okay, and then if the area is less than 1.2 cm square, then you can confirm aortic stenosis. So if you confirm there's aortic stenosis, you want to know, is this low gradient? Aortic stenosis with low or preserved ejection fraction, and then if you find out that it's low gradient as the ejection fraction is preserved, you go ahead to do the calcium score. Okay, so if you do the calcium score and it's greater than 2000 in men, it can be greater than 2000 in men or 1200 arbitrary units in women. Okay. And then for low gradients with reduced ejection fraction, you do the stress echo. And then if the pressure is still greater than this, and then the area is less than 1.0 square, so you go on to do the support as well. It should now help in the next step on what to do. So the definitive treatment requires mechanical intervention. Whatever we do medically will be to buy time and then to help relieve symptoms, but eventually they will need some mechanical intervention. And then advice on avoiding strenuous physical activity. It's important. And then it's important to know that no drug just reverses aortic stenosis. So we should prescribe appropriate medical therapy for associated risk factors. If they have coronary artery disease, if they have atrial fibrillation, diabetes mellitus, heart failure, hypertension, or dyslipidemia, as the case may be. Okay, so just quickly now about the replacement for using surgical aortic valve replacement. It's a traditional method. It is definitive and time-tested, and then uses a bioprosthetic valve instead of mechanical valve. Most times they have to do a full stenotomy, but the other aspect of partial and mini thoracotomy are becoming increasingly popular. And then mortality rate is less than 3%, and less than 2% in low risk overall. That's those that have high, medium or low. It's less than 3% and less than 2% for those who are low risk patients. And then the common reasons for wanting to avoid SAVA, the contraindication is when you have an advanced age individual, when there are several comorbidities or the patient is actually frail. Then in 2011, the transcatheter aortic valve replacement, TAVA or TAVI, TAVI is the intervention, became available. And then it's been shown to have some level of equal status with the SAVA, especially in high risk and intermediate patients. Okay. So the usefulness in lower risk. Hello, sir. Okay, the usefulness in lower risk patients remain undetermined. Trying to rush this now. Okay, well suited for patients with advanced age, like we saw extracardiac comorbidities or anatomical factors that will complicate an open surgical approach. So this will just tell us it's from the guideline which favors either TAVI or SAVA. When there's low surgical risk, it favors more of this surgical approach. Okay. And if there's higher risk, you think more of doing the transcatheter aortic valve. And then at younger age, they favor more of, then older age, will favor more of TAVI. Then if you had previous cardiac surgery, and particularly intact coronary artery bypass graft or risk of injury during repeat stenotomy, that would favor use of TAVI. And then for patients who are severely frail, even though this has some extent to it. So for each of them, the choice can be guided. And then if you can have TAVI feasible through transfemoral approach, of course it will favor TAVI. And then transfemoral, if transfemoral approach or access is challenging or impossible, and then survey is possible, then you go for survey. Okay. So if it's as a result of sequelae of chest radiation, it's better to go for the TAVI. And then if you have percent aorta. So almost rounding up now, the choice of treatment actually will vary. There are many factors to consider: age, comorbidity, access, the kind of pathology that's involved. For example, you can see here, if you have the disease as a bicuspid aortic valve, it favors doing more actually a surgical valve and replacement than transaortic. However, if you have an elderly patient that is frail, is weak, has several comorbidities, and you're wondering what is the life expectancy after even the procedure, it is now better to do a TAVI. Okay, so there are several of them. If there are concomitant cardiac conditions that require intervention, okay, for example, a significant multivessel pulmonary artery disease, and this requires surgical revascularization. So at the time of doing this, it's just safer to do a surgical valve replacement. If there's also severe primary mitral valve disease or severe tricuspid disease, mitral valve, severe tricuspid valve disease, the choice of treatment favors more of doing a SAVA instead. And lastly, if you're doing a septal hypertrophy, with a septal hypertrophy requiring myectomy, it is better to do a SAVA. So recommendations on medical therapy. As said earlier, no medical therapy influence the natural history of aortic stenosis. Statins, which demonstrate favorable effects in preclinical studies, they do not affect the disease progression, and clinical trials targeting calcium metabolic pathways are currently ongoing. Patients with heart failure who are unsuitable for SAVA or TAVA should be medically treated according to the ESC heart failure guidelines. Okay, so the ACEIs are safe in aortic stenosis, provided the blood pressure is monitored closely, and they may have beneficial myocardial effect before the onset of symptoms. And then they can be used even after TAVR or SAVR. Okay, coexisting hypertension should be treated to avoid additional overload, although medication, particular vasodilators, should be titrated hypertension. Thank you very much. I don't know if I should go on to talk about aortic regurg.
I think you should wait till maybe tomorrow so that we can ask questions and address this, but this is so excellent. I think so.
Okay, sir. Thank you, sir.
This is so. Well, that's my thought. It's open to the class. Do you think we should take the aortic regurgitation and finish it up today? Just going for exams. That's my own thought. That's why I said I think we should. Hold on. Ade Andrew, sorry, Conte. Please, let's speak up if we still want to speak up.
Hello, sir. Good evening, sir.
Good evening, boss.
Good evening, Chief, sir. Good evening, Dr. Kwesi. There is no other thing we are having as this that we can finish up. If not, we'll wait till tomorrow. So we still need response from Chief on the platform.
All right, so let me call Lynn so that we'll not be waiting for Ayodeji. What do you think? Ayodeji.
Hello, Chief.
Yeah, you're going for exam. So what do you think? Should we finish it up or should we just analyze this one and then continue tomorrow? Since we don't have anything, your chief rep is saying that we should finish it up.
We can finish.
All right, that's
Since
fine.
we don't have
Any
any
other
other
question?
thing.
All right, that's great. So let's hit the ground running. Dr. Alex, if you have the energy, please take some sip of water and Lucozade boost. Let's hit the ground running.
Oh, okay, sir. Thank you, sir. Thank you, everyone. So I may be faster here because time. So for aortic regurgitation is the diastolic reflux of blood from the aorta into the left ventricle across the aortic valve. Okay, so it can be caused by either when you have a damage to or dysfunction of the aortic valve leaflets, or as a
Okay,
consequence.
Dr. Alex, sorry, 1 second. You are actually doing excellently well. I'm very proud. And somebody just made a comment on the page. Okay, that's Rukaya. She's asking if we should make comments or we should wait until we finish all together. I think you can make your comments on the chat box as we are going, and then at the final end, you can unmute your mic and speak on your comments so that we don't break through. So we can start chatting it up on the chat box so that we can remember, and then at the final end of everything, you can Alex will respond to them, or you can unmute your mic and throw more light on your comments. All right, thank you. So, Dr. Alex, please,
Okay,
you have the floor on the table.
Thank you, Dr. Okopi. So when we talk about a regurg, it's an incompetence. So there's a diastolic reflux of blood, and this is coming from the aorta because we're talking of aortic regurg into the ventricle across the aortic valve. So it is usually caused by either a damage to or a dysfunction to the aortic valve leaflets, or as a consequence of distortion and dilatation of the roots. So we're either talking about the valve itself, the leaflets, or we're talking about the roots, okay? And then it can be caused by either primary disease of the aortic valve leaflets or the wall of the aortic root, okay? So valvular causes are becoming less frequent and aortic root causes are becoming more prominent. And the aortic root dilatation causes actually account for more than 50% of cases. It's important to remember. And then the prevalence of aortic regurg depends on the age and the severity of the condition. So it's said to be usually uncommon before the age of 50, but above 50 can now begin to see. And then there was a population-based cohort study, the Framingham Heart study, where the prevalence of moderate to severe aortic regurgitation was 0.5, 0.6, and 2.2 in men at ages 50 to 59, 60 to 69, and 70 to 83, respectively. If we look at the corresponding rates for females, we'll see that it is a bit lower, except when we now, it's higher, it's lower for the initial moderates. Okay, so when you have moderate one, for example, in male 0.5, female 0.2, then progressing upward to severe aortic regurg, you have 0.8 for females, 0.6 males, 2.3 that way. And then it's important to recall that aortic regurgitation has several signs, and it's called a disease of many eponyms. And this is characteristic to aortic regurgitation more than any other clinical condition. So for aortic regurgitation, it can either be acute or chronic. In acute, there's no form of left ventricular dilatation, or any of those things. So it's just happening at the time that there's no any other compensatory mechanism, so to say. So for acute aortic regurgitation, you have things like acute rheumatic fever, infective endocarditis, dissection of the aorta, and rupture of the sinus of Valsalva, and then failure of prosthetic valve. These are causes of acute aortic regurgitation, and a number of times they are actually emergencies compared to the chronic aortic regurgitation, which take time. And like we said earlier on, there can be affectation of either the valve or the valve roots, the leaflets of the valve. So we can have congenital causes, and we can have connective tissue disorders like Marfan's, Ehlers-Danlos syndrome, rheumatic valvular heart disease, Takayasu arteritis, rheumatoid arthritis. There's so several, vasculitides and conditions that can affect either the valve leaflet itself or their roots. Okay, and then use of appetite suppressants like fenfluramine, and this has been shown to affect the aortic roots, and has also been shown to affect the aortic valve embryology as early as 4 to 7 weeks in utero. Other causes like pseudoxanthoma elasticum, syphilitic aortitis, osteogenesis imperfecta, and then for the causes of root dilatation, there are also several. For example, long-standing uncontrolled hypertension. It can be from age-related aortic dilatation, from idiopathic aortic dilatation, aortic dissection. It's a known cause of aortic regurgitation, syphilitic aortitis, Takayasu, SLE, ankylosing spondylitis, Whipple's disease, Behcet's, and a whole lot of other things. Okay. So, but less common causes of aortic regurgitation occur in association with Charcot arthropathy, Crohn's disease, osteogenesis imperfecta in psoriatic arthritis, ulcerative colitis, and then like I mentioned this already, the drugs that have had effect with this. So what is the pathology here? It's usually when the aortic annulus becomes greatly dilated. Okay, so the aortic leaflets separate, and then this may cause regurgitation, right? Or you have dissection of the diseased aortic wall that may occur and aggravate the aortic regurgitation that's already there. Then you can also have a dilatation of the aortic roots, and as a result of secondary effects on the aortic valve, because the dilation causes tension and bowing of the individual cups, which may thicken and retract. Okay, so we see that the problem is not really about the leaflets, it's now about the roots. It's causing some inability of the leaflets to fully coapt. Okay, so these defects that we find in the aortic dilatation leads to intensification of aortic regurgitation, and this further dilating a ascending aorta and leading to a vicious circle in which, as for mitral regurgitation, more regurgitation actually leads to more regurgitation. Okay, so for this image here, we can just see this is the anterior mitral valve leaflet. We can see the right non-coronary and the left cups of the aorta, and we can see that this is normal. Okay, so in ventricular diastole, where the pressure is about 80 millimeter mercury, you have that these valves are actually closed. Okay, right. So, but if you now have abnormalities like when you have the congenital bicuspid, okay, or when you have infective endocarditis, okay, or you have infective endocarditis occurring in the setting of bicuspid valve, which can be common. And then other conditions, these are conditions where there's some abnormality in terms of the valve themselves, okay. Then if you look at ankylosing spondylitis, where you can have thickening of the cusp, somewhere here. If you compare it to the normal, you see that the margins are actually thickening, okay. And then the aortic wall also appears thickening in them as well, okay. So this whole diagram is just showing that there are some changes that do occur in the various causes of either a root dilatation or affectation of the valves themselves. Okay, so functionally we can have like a tear, an aortic tear, which is what we're seeing here, or laceration, which can occur from an aortic dissection. Okay, so you have this type of dissection. You can imagine what will now happen around here, where the tear has occurred. Then we can have degenerative changes as well, okay, which can cause some dilatation. They can cause some thickening of the cusp, okay, and then prolapse can also occur. So when we contrast any of these pathologies and look at the normal pattern of the placement of the valves and their nature, look at also the position of each of the valve leaflets, it gives an idea of what can happen in each of the conditions. Okay, so this is still continuing. We can have a rheumatic heart disease, a valve disease, with or without commissural fusion. Okay, and systemic hypertension too has its effect. Other conditions like rheumatoid arthritis, Marfan's and Ehlers-Danlos, they all have an effect. And rheumatoid arthritis, you can see some deposition of the rheumatoid nodules in the valve. And definitely, if you look through here, as this occurs, that will definitely affect the competence of these valves, which can now allow for a leakage or a backward flow from the aorta into the ventricle. Okay, so in terms of the grading for echocardiography, we can do either a semi-quantitative or a quantitative method. In the quantitative method, we're actually measuring the regurgitant volume, and then the regurgitation fraction, and then the effective regurgitant orifice, okay? And this is done using the proximal isovelocity surface area divisor. So, but for the semi-quantitative way, we look at the LVOT width ratio, the LVOT area ratio, look at the vena contractile. I think most of us, we do a lot of the quantitative, then the continuous wave signal density, pressure half time, which is the most reliable way to check for an acute aortic regurgitation, and diastolic flow reversal of thoracic abdominal flow. So if we can look at these jets here, we will see that at this point, this is the aorta. Okay, so you have a backward flow coming this way. So at this point here, this is what will be described where you have this confluence. This is where you describe as the vena contracta. Okay. And measuring this vena contracta also has guidelines on how it should be done, and is important because the vena contracta measurement also adds up or helps us to describe whether aortic regurgitation is mild, moderate, or severe. Okay, so as the backward flow occurs and then you have the regurgitation, all the way you can see the mosaic pattern in which it is occurring, and then you look out for the neck or the region where it's contractors for the vena contracta area. So based on the measurements we have, we can look at the LVOT. Okay, let me just explain this from the parasternal short axis view. You can see that there's the LVOT area and then the LVOT jet area. So the measurements would be, like I said earlier on, and then you can now, based on the jet's velocity ratio, which is a form of semi-quantitative method, and then the jet LVOT area. Both are forms of semi-quantitative method. While for measuring the regurgitation volume and the fraction, that will be quantitative. So for mild aortic regurgitation, we'll see that the LVOT width ratio will be less than 25. Then moderate between 25 and 64, and then severe is greater than this. Then for the vena contracta, less than 3.6, greater than 6. And then the LVOT jet ratio also. So for mild, it will be LVOT width ratio, vena contracta, and then LVOT area ratio will be less than 5% as you go down respectively. Okay. So if we look at the pattern of the aortic regurgitation now, if you look at the intensity of this, you can see that there's some difference in terms of intensity. Okay, this shows that the intensity is a bit low and the intensity at this point is high. Okay, so this is a semi-quantitative method in terms of measuring the aortic regurgitation. Okay, so if we look at the top panel, look at this top panel here, the color Doppler, which is now zoomed in the parasternal long axis view of the aortic valve, shows the aortic regurgitation jets and parameters that correlate roughly with the grade of aortic regurgitation. Okay, as we saw in the charts previously. Okay, so the bottom panels here show us the left ventricular panels and using continuous wave flow for the aortic regurgitation. And this is usually best in apical 5 chambers and to show the density of the continuous wave jets in diastole relative to the forward flow envelope. Relative to the forward flow envelope. And this would also correlate with the level and severity of aortic regurgitation. Okay, so for the looking at the quantitative method, one of the ways to measure the regurgitant volume, and then the regurgitation or the regurgitant fraction, and then looking at the effective regurgitant orifice too. These are all measures to look out for severity in them. So in terms of their classification now, they are classified as mild, moderate, or severe. And this is based on the angiographic grade. Okay, whether you have the contrast enters the left ventricle. If you are using angiography, there's also you can use angiography to grade. You can give some data that helps to grade this. For example, if you have that the contrast is entering the left ventricle and it clears after systole, you see the contrast, it enters in diastole, it clears after systole, that is likely mild. Okay, but if the contrast enters the left ventricle and then you see opacification of the entire ventricle, left ventricle, then you can say that is moderate. And then for severe, you have the opacification of the left ventricle much more greater than what you have at the level of the aorta. Then looking at the jet width is also important, and then the regurgitant fraction, okay, and the orifice area. So in mild aortic regurgitation, by the time you put the contrast, it enters the left ventricle where it clears with systole. And then in this one, you have that the jet width will be less than 25, the regurgitant fraction 30, less than 30, and then the orifice area, the regurgitant orifice area less than 1. So for the moderate form, there'll be a pacification of the entire left ventricle, and then the width or the percentage of the LVOT will be 25 to 65, and then the fraction of regurgitation will be around 30 to 49. And then the area will be bigger, of course, because you're not having it moderate. Then in severe, you have a wider area, 0.3, and then the regurgitation is now much more than or equal to 50. And then the jet width percentage of LVOT is greater than 65. Then you have a pacification of the left ventricle much more than the aorta. And then just like we had for aortic stenosis, there's also staging for aortic regurgitation based on like stage A, stage B, and then the stage C, and then D. But unlike in aortic stenosis, you don't have like severe symptoms with this, with that. This is a rather straightforward. Like for stage A, they're talking of those who are at risk of aortic regurgitation, and this will include individuals who may have bicuspid aortic valve or other congenital valve abnormality, individuals with aortic valve sclerosis, disease of aortic sinuses or the ascending aorta, history of rheumatic fever, or if they are known rheumatic heart disease patients or have infective endocarditis. So in these patients, the valve hemodynamics would be that the aortic regurgitation, and there could be none in terms of severity, and then no hemodynamic consequences, and such patients at stage A may not have any symptom. Then when you move to stage B, which is a progressive aortic regurgitation, there's mild to moderate calcification of the trileaflet valve of the bicuspid aortic valve, and or congenital valve anomaly, dilated aortic sinuses, rheumatic valve changes, and then they might have had a previous infective endocarditis. Okay, so for this one, you have the progressive is known as the mild aortic regurgitation, where the jet width is less than 25% of the LVOT. Then the vena contracta is less than 0.3. Okay, all the way down to angiographic grade. Most of them may not even have symptoms still at this point. And then they might have normal left ventricular systolic function. Then at stage C are those that now have, they are still asymptomatic. Okay, they're called asymptomatic severe aortic regurgitation, while stage D are symptomatic severe. So stage A is at risk, stage B, progressive aortic regurgitation, stage C, asymptomatic severe, then stage D is symptomatic severe. So for the asymptomatic severe, they already have a calcific aortic valve disease. That's those that may have calcific aortic valve disease. When we're looking at the anatomy now, you can also have bicuspid valve or other congenital anomalies, dilated aortic sinuses, or ascending aorta. They can have rheumatic valve changes, infective endocarditis with normal leaflet closure. Okay. And then when we look at their parameters, they meet the parameters for severe aortic regurgitation, from the jet width to the vena contracta, to the RF, to the effective regurgitation orifice, and then from the angiography as well. Okay, so in terms of their hemodynamic consequence, you can now see that at C1, they may have the normal ejection fraction. They have normal ejection fraction and mild to moderate left ventricular dilatation. Okay, so the left ventricular end systolic diameter will be less than 50. And then at stage 2, they have abnormal left ventricular function with depressed left ventricular ejection fraction or severe left ventricular dilatation. So by the time we get to the symptomatic severe now, all of those parameters will be much, much higher in them. Like the jet width will be more than 65, the vena contracta as well will be more. Okay, and then the effective regurgitant orifice 0.3. So I think in our spare time we can look at this slide again to help us recall what we find in those at risk, those at with progressive disease, those with asymptomatic severe, and then the symptomatic severe. Okay. But I think we can work it out if we know that the major thing we look out for is what is the width of the jet, the vena contracta, what does it look like, and then the effective regurgitant orifice, and then even the angiographic grid. Then we'll be able to work this out. So just to say that it may be a chronic disease process or it may occur acutely. And when it occurs acutely, it can just present with heart failure. Okay, because of the sudden overload that can occur. Then in acute aortic regurgitation is a medical emergency. I may need immediate surgical intervention. Unlike the chronic one that the person is already compensating well, may not need that kind of immediate intervention. The most common cause of chronic aortic regurgitation used to be rheumatic heart disease, but currently it is commonly caused by bacterial endocarditis. It's said to be the commonest form now, bacterial endocarditis. And then in developed countries, aortic regurgitation is caused by dilatation of ascending aorta. Common causes of acute aortic regurgitation include infective endocarditis, aortic dissection, and trauma in that order. Okay, so this diagram here just helps us know what is occurring when you have aortic regurgitation. It's some form of diastolic regurgitation. Definitely there will be an increase in the left ventricular volume, which can cause an increase in the mass. And when this occurs, with the volume, the mass can increase because of the pressure it needs to now overcome to push out. So we have increase in left ventricular mass and cause a left ventricular dilatation. If this is unchecked, it now leads to heart failure. Okay, so and as well, stroke volume is increased, can increase systolic blood pressure, which can either cause an increase in left ventricular mass or can directly cause left ventricular dysfunction. And if you have an increase in systolic pressure, this can increase myocardial oxygen consumption, which can cause a form of myocardial ischemia and then can lead to failure. Okay, so even if you have from this pathway coming to failure, it can also feed back to cause a myocardial infarction and then cause an increase in left ventricular end diastolic pressure, which will increase backward flow to the lungs and lead to dyspnea, apnea, and the symptoms they can have. So the next slide now, we'll just look at it being chronic and acute. So in chronic aortic regurgitation, it usually has a long asymptomatic phase, while for acute aortic regurgitation, usually occurs suddenly when you have an aortic valve incompetence. And in the acute aortic regurgitation, you would have a non-compliant left ventricle because everything is occurring so suddenly and might require immediate surgical intervention. Okay. Then for the chronic aortic regurgitation, you have the total stroke volume causes hyperdynamic circulation, induces systolic hypertension, and causes pressure and volume overload. And compensation is by concentric eccentric remodeling, because this occurs over a long time. Okay, and this can now lead to progressive left ventricular dilatation, dyspnea on exertion, orthopnea, PMD. And because of the dilatation, they can now begin to have premature ventricular complexes. Then for the acute form, we know that there's no dilatation at this point because it's acute. And then we don't have the classic hyperdynamic findings. So they can have high diastolic left ventricular pressure. The high diastolic left ventricular pressure causes mitral valve preclosure and potentiates left ventricular ischemia and failure. These ones predominantly can have an acute pulmonary edema. So what are the physical findings we can have in these patients? One, we would notice they would have a wild pulse pressure. You can imagine a systolic of 170 and a diastolic of 60. So they usually have wild pulse pressure with 70 millimeter mercury. Then they have low diastolic pressure. Then is a disease of many signs. So one of the signs, the Lucet sign, which is the head nodding with each pulse, the Corrigan's pulse, which is the water hammer pulse or collapsing pulse. There's also the Durosay's murmur, which is femoral artery and femoral artery auscultation, Traoré sign, which is a piston short femoral artery auscultation. We can have diminished second component of the second heart sound, aortic component of second heart sound, the crescendo diastolic blowing murmur, which is heard at the left sternal border. And the classical murmur they have is called the Austin Flint murmur, which is a diastolic flow rumble at the apex, and is due to interference with transmitral filling by impingement from aortic regurgitant jet, fluttering of the anterior mitral leaflet or septal wall. Okay, there's also the Cole-Cecil murmur. The Cole-Cecil murmur is a diastolic murmur that is near the axilla and mid left thorax. Is caused by fusion of the aortic murmur with S3. Okay, and then it is due to simultaneous filling of the left ventricle from the left atrium and from the aortic regurgitation. Okay, so there are other signs of pulsation, like for the signs of pulsation now associated with this, we have the Baker sign, the Rosenberg, Gayhart sign or Saylor sign, the Shelley sign, and the Quincke sign. These are related with pulsations. Like the Baker sign is related with retinal artery pulsation, the Rosenberg sign, the liver, Gayhart sign, spleen. Pulsation of the cervix is the Shelley sign, and then the nail bed capillary pulsation, that's the Quincke sign. So popliteal systolic pressure can be greater than 60 millimeter mercury, higher than the brachial pressure. This is what is known as the Hill sign. I can check the difference. Okay, and then there can be a fall in diastolic pressure of more than 15 millimeter mercury with arm elevation, main sign. Then you have the Landolfi sign, which is systolic contraction and diastolic dilatation of the pupils, Landolfi. Then you have the lighthouse sign, which is alternative flushing and blanching. Lighthouse, alternating flushing and blanching of the forehead. Other signs like Lincoln sign, where you have excessive popliteal artery pulsation, Schema sign, prominent pulsation of the nasal pedis artery, and the palmar click, where there's palpable abrupt palm flushing in systole. So aortic regurgitation is a disease of many eponyms and many signs. So this mnemonic, if we can catch it, I think it will help us remember a ratty got low quality BCG, DPT, and MMR from PHC. Okay, at least we will remember these vaccines, so that may help us. So a ratty got aortic got low quality BCG, DPT, and MMR from PHC. Okay, so for now, put it together, aortic got. So the AR here, if you notice the ones that are in capital are what we're focusing on, right? So aortic, AR, aortic regurgitation. The G is for Gerhardt sign. The L, Landolfi. Okay, Q, call it green case. Then the B is Baker's. The C is Corrigan's. G is Gerhardt, Demosets, and on. So you have MMR, Muller sign, main sign, okay, and Muller's main sign. Then you have the Rosenberg sign. So then the PHC will now be pulsus by pharynx, the Hughes sign, where you have a systolic popliteal systolic pressure greater than 60, higher than brachial pressure. That's the Hughes sign. And then you have the collapsing pulse, which is the Corrigan pulse sign. So if we can remember this acronym or mnemonic, maybe it will help us just recall this disease with many opponents. Okay. So what do we do in terms of investigations? We can see LVH with string when we do an ECG for them. And then we can also see when we do chest X-ray for these patients, you can see what is known as the core bovinum, okay, which is a massive hypertrophy of the left ventricle due to volume overload. Core bovinum it has to do with overload. We have an overload. Then for aortic regurgitation, because of the sudden rise in the left ventricular diastolic pressure, this would lead to some form of pulmonary edema. But in this case, we'll have pulmonary edema with normal sized hearts because this is happening acutely. Okay, so on 2D echo, we'll access the aortic valve and the roots. Looking at the roots, the sinotubular junction, we'll look at all this area on 2D echo. And then we'll access the left ventricular function and dilatation. Okay. And then the dimension too of the left ventricular end systolic diameter, what it will look like in diastolic. So then we'll now do a Doppler severity or regurgitant jets view. So for the treatment of aortic regurgitation, long-acting calcium channel blockers, nifedipine has an advocated use of ACIs, diuretics, or nitrates that will help to reduce the preload. And then antibiotics against infective endocarditis is indicated for patients who have had valve replacement. For the surgical intervention, they can also have balloon aortic valvuloplasty. This is usually a short-term measure to have something more permanent, but can be effective in reducing symptoms in them as well. Then the Ross procedure, which is an auto transplant, is a procedure in which you take the pulmonic valve to the aortic position, okay, and then you also now do a holograft, or you now take care of the pulmonary valve itself. So it's like a switching on. And then it is usually done for those who are younger, not those who are older. Then valve replacement also is surgery. It can be done in that. So what's the indication for surgery for them? When they have increasing symptoms, when the heart is enlarging from what it was previously, and then you have changing ECG signs, deteriorating. Then when they have infective endocarditis that is refractory to medical therapy. Okay, so the Ross procedure is what is known for aortic valve surgery which I've just explained, talking about the auto transplant of the pulmonary valve to the aortic position. Take the pulmonary valve, move it to the aortic position, and then reimplantation of coronary arteries around it. And then you do a homograft valve for the pulmonary position. Indications are here for younger patients. Does not require anticoagulation. Okay, and then it requires similar size aortic and pulmonary, so it's a challenging procedure. So what is the prognosis for these patients? Chronic aortic regurgitation can be well tolerated for many years and is associated with good prognosis. For 5-year survival up to 75%, 10-year survival to 50%, and the prognosis worsens as symptoms come in on left ventricular dysfunction and dilatation. So acute severe aortic regurgitation, however, is associated with high mortality from left ventricular failure, and early intervention is indicated because the individual does not have time for the compensatory mechanisms, okay, to build up. So how do we handle aortic regurgitation? Again, class and the evidence just around here. Okay, so if a patient has aortic regurgitation, we want to know, is this stage C or D, which is the severe? C as severe is symptomatic, D is severe symptomatic, or is this patient stage B? We don't bother about A because A is mostly at-risk individuals. So looking out for or correcting the risk, we handle that. And then for stages C and D, you look at the vena contracta, it's more than 0.6, it's large. And then the holodiastolic aortic flow reversal, okay? The reversal volume is more than 60 mils per beat, or the reversal fraction is more than 50. Okay, the effective regurgitant orifice is more than 0.3. And then is there left ventricular dilatation? These are the things to look out for when you are looking at severe. And then if it's stage D, where you know it's already severe aortic regurgitation, it's class 1 evidence to go straight for aortic valve replacement. Okay, but see, you still look out for other things. Is the ejection fraction less? You go for replacement. If there's other cardiac surgery, and then if the left ventricular end-diastolic diameter greater than 50, the EF more than 50, and is in stage 2, 2A class of the replacement. And then it goes on. So for the progressive one, which is you have the vena contracta, is still less than 0.6. The regurgitant volume is less than 60. The fraction is less than 50. The orifice less than 0.3. And then you ask, will this person be going for any other cardiac surgery? If it is yes, then you go ahead to do a valve replacement. But if this person is not going for any other surgery, as in just the progressive disease, you just do periodic monitoring for them. So for the echocardiographic criteria for the definition of severe aortic regurgitation, you look at the valve morphology, the color flow, regurgitant jet area, the continuous wave signal of the regurgitant jets, okay, and then the others. So for the valve, we look at for abnormal valves, whether they are frail, have large coaptation, look out for defects. And then in terms of the color flow, regurgitant jet area, it's usually large in central jets, variable in eccentric. And then the continuous wave, usually dense, you see them dense for a severe aortic regurgitation. And then holodiastolic flow reversal in the descending aorta, maybe more than 20. And like we said earlier on, there's the semi-quantitative and the quantitative. So if you look at the semi-quantitative, you are looking at the vena contracta, more than 6, less than 6 will not be severe, but more than 6 is severe. and then the pressure half time, which is very, very important if we have a patient with acute regurgitation less than 200. Then for the quantification, the aortic regurgitation orifice area more than 30, the regurgitant volume. These are also important and help us to define the severity. So recommendations in terms of medical therapy: chronic aortic regurgitation, where surgery is not feasible, ACIs, the dihydropyridines should be considered for symptomatic improvement. Asymptomatic moderate to severe AR, you can use ACIs. Using ACIs and dihydropyridines, they have no benefits, so they are not recommended in them when they are asymptomatic moderate. So patients who undergo surgery but continue to suffer from heart failure or hypertension, then we can use these other medications because we're controlling the heart failure essentially. So in patients with Marfan syndrome, beta blockers remain the mainstay for medical treatment and should be considered before and after. What does the guidelines say? I'll just run through this now. The 2021 European Society of an Association of Cardiothoracic Surgeons, the guidelines about this already, the class of recommendation, and then what they say as indication for surgery recommended in symptomatic patients. Function. Before it used to be hinged on what 2021 guideline says, regardless, plus 1B, surgery is recommended in asymptomatic. The left ventricular systolic diameter is more than 50. Okay, or if it's very surface area in patients with small body size. Left ventricular ejection fraction less than 50 is also plus 1B level of evidence. It may be considered in asymptomatic patients who have left ventricular systolic diameter of 20 millimeter, body surface area, and left ventricular ejection fraction less than 25. This is if surgery, and this is plus 2B. Level of evidence, C. So the other talks about surgery is recommended in symptomatic and asymptomatic patients with severe aortic regurgitation undergoing CABG or surgery for ascending aorta or other valve. This is 1C. Yes, since the person is already undergoing surgery, it's just important to also replace the other. So aortic valve repair may be considered in selected patients at experienced centers when durable results are expected. Okay. Then the indications for surgery. Okay, so as well, you have when the aortic root or tubular ascending aortic aneurysm, irrespective of the severity. Okay, so when you have aortic root or tubular ascending aortic aneurysm, irrespective of the severity of the aortic regurgitation. Okay, so you have a valve sparing aortic root replacement is recommended in your patients with aortic root dilation if performed in experienced centers and durable results are expected. That's 1B level. Okay, class 1, level B. And then ascending aortic surgery is recommended in patients with Marfan syndrome who have aortic root disease with a maximal ascending diameter, ascending aortic diameter greater than 50 millimeter. Okay. Then for ascending aortic surgery should be considered in patients who have aortic root disease with maximal ascending aortic diameter that is greater than 55. okay, in all patients, but for patients who have Marfan syndrome, it should be less, 45, okay, and then greater than 50 in the presence of bicuspid valve with additional risk factors for coarctation. Okay, all these are level 2A, C. Right. So what's the management algorithm for these patients? So to manage patients with aortic regurgitation, we're looking at, is there significant enlargement of ascending aorta? That has to be answered first. So if the answer is no, you look out for the, you made an assessment of severe aortic regurgitation, you look out for symptoms. If there are symptoms, you know that you have to prepare this patient for surgery. If there are no symptoms and the left ejection fraction is less than 50 or the left ventricular end systolic diameter more than 50, if this is yes, you still go for surgery, or if it is no, you can do a follow-up, okay? So, but if the assessment is, if severe aortic regurgitation is not likely, you just do a follow-up and see. However, if there are symptoms or this is present or you have significant enlargement of the ascending aorta, you just go straight for surgery. Okay. Then when there are other comorbidities, the guidelines also say, for example, those who have coronary artery disease, coronary angiography is recommended before valve surgery in patients with severe valvular heart disease. Okay. And this is at class 1C, okay, and then there are other conditions too, like those who are going for myocardial revascularization surgery, okay, and then the presence of atrial fibrillation in them for anticoagulation, for stroke prevention in atrial fibrillation patients who are eligible for oral anticoagulants. NOACs are recommended in preference to VKA in patients with aortic stenosis, aortic and mitral regurgitation. This is class 1A, okay? So the use of NOACs is not recommended in patients with AF and moderate to severe. This is mitral. Okay. So other aspects of recommendation in terms of the surgery. So just summarizing now that whenever we have either a dilatation of the roots or we have lead to a failure in coarctation, we can have aortic regurgitation and cause a dysfunction. Okay. Causes are becoming less. We now have more of aortic root causes, and the aortic root causes actually account of the cases, and it's a disease of several eponyms and usually seen in more than 50 years of age. The acute form will require immediate emergencies that require intervention, but the chronic form would still gives, it develops or progresses over time. These are some of my references.
Wow. Thank you so much, Dr. Alex, for the detailed, excellent presentation. One of the things I love so much is your slides were very elaborate, very scientific, and very wonderful. And the pace at which you spoke all through was very stable for such a lengthy presentation. Thank you so much, sir. So it's now time for...
Thank you for the privilege, sir. Thank you.
Thank you. Quite a scintillating, quite detailed, and a beautiful presentation. So it's now time for mind rubbing. Please permit us to pick your brain. We'll start in some form of orderly format. For those not going for exam, please, you can speak. Those going for exams, and then our fellows in the house, and then we'll go finally to the facilitators. Permit me to pick you up randomly, even if you don't have something to say. You should be able to say thank you for a wonderful presentation so that your voice can be captured. So the floor is open. We can make our contributions, comments, and questions. Let's start from those not going to exam. Dr. Florence, and go ahead.
Yeah. Okay. Yeah. Good evening, everyone, senior colleagues and colleagues. Thank you so much, Dr. Itubu Ibrahim. The presentation is actually aortic valve disease is actually very vast, and then you took your time to actually explain all of these to us. So kudos to you. Well presented. Okay, so I want you to go over to your slide on aortic stenosis. There's a part where you actually, it was handwritten. You actually screenshot and then added to your presentation.
Okay. Just a minute. So it's not very clear. Yeah.
Okay, so basically, I just want to add, just make a little comment about this presentation, this particular page. You know, you made mention of in moderate aortic stenosis. We actually hear a single. What did you mention there? Sorry, under moderate, just an A2. What did you said? A single what? What did you say there, please? Can you please get me back to what exactly you said for moderate aortic stenosis?
Usually, you should hear the second component, okay? The second heart sound, you have two components. So when you have, hello?
Okay, so you said for moderate, we actually hear a single component,
Yes.
right?
A single component.
Okay, so
and that's the A2
okay.
because of delayed AV closure. AV closure delays until it coincides with the closure of the pitch.
Okay, so basically, what I just want to add to this, we all know that S2 is actually heard when the AV valves are actually closed. And then the aortic and the pulmonary valve actually close at the same time, but not at the same time per se. The aortic valve actually closes a little faster than the pulmonary valve. So, in this moderate or in stenosis generally, the mobility of the aortic valve is actually reduced. So that's why we actually hear a single sound or whatever you called it. Because what happens here is that the aortic valve that is supposed to close a little faster than the pulmonary valve then delays. And then what happens is that the pulmonary valve then closes at the same time with the aortic valve. So that's why we hear that single sound, because the valves actually close at the same time in moderate aortic stenosis. So now in the severe aortic stenosis, the more severe the stenosis, the reduced the mobility of the valves. So what happens here is that the pulmonary valve then closes a lot faster than the aortic valve because the mobility of the valve is actually slower. So that's why we now have a reversal, meaning that the pulmonary valve closes faster than the aortic valve in severe aortic stenosis. So that's just what I just want to add to this particular picture you put up here. Then, secondly, the aortic stenosis generally talks about the Bernoulli's equation, where the area of the valve is actually inversely proportional to the mean pressure gradient and the peak velocity. So what I'm trying to explain here is that Bernoulli's equation basically talks about three things: the height, the pressure, and the speed. Height being the level of stenosis, pressure being the mean pressure gradient, and then the speed being the peak velocity. So basically, what happens is that in a stenosed valve, because what happens is that there's reduced blood getting into the ventricle, there's reduced blood getting into the systemic circulation. So what happens is that the body tries to compensate to try to increase the ejection fraction. So what happens is that because the valve is stenosed, so we need more pressure to be exerted against the stenosed valve. And again, so we need more speed, you understand, against that stenosed valve so that the ejection fraction can actually be increased and then meet up the demands, you understand, to the body generally. So that's why you were trying to explain to us that when you notice a patient who has aortic valve area being less than 1, it's expected that the mean pressure gradient should be more than
I can't seem to hear her. I don't know if anyone can. Or is my network? Hello?
Oh, I can't hear her either. Maybe we lost her.
All right.
Network.
Okay. So,
Network.
okay. All right.
Yeah,
So
hello.
is it?
She's back.
Hello.
Okay, I think she's back. All right, go ahead. We're not hearing you at some point, so I don't know if
Okay,
you
so
can just
sorry, where did you
step
hear me
back.
last? Sorry.
You were talking about the mean aortic gradient.
Hello? I'm not hearing you so well. Hello,
You're
sorry, where did
talking
you
about
hear me last?
You are talking about this slide. The area.
Okay, the area. Okay, what did you hear me when I talked about the Bernoulli's equation?
Yes, we did. Thank you.
Okay, so I was trying to talk about vena contracta. I don't know if you got to that point. Okay, so basically, you made mention of we are supposed to take the measurement at a particular time. In diastole, that's when the aortic valves actually close. So in regurgitation, what happens is that the valves actually they lag behind. Either the anterior or the posterior leaflet or both actually lag behind. So it's expected that in diastole, the valves are not going to collapse properly because there's a form of regurgitation, there's a form of lagging of the aortic valve. So what happens is that the measurement is actually gotten at diastole, basically at the end diastole, when it's expected that the valves are supposed to collapse properly. So what happens is that if you, like from what you mentioned, that the higher the vena contracta, the more severe the aortic regurgitation. So it's expected that the higher the regurgitation, the more the diameter or the more the width, or how do I explain it? The more the farther apart the valves will be. So basically what happens is that we measure the width from the tip of both leaflets. So in severe aortic regurgitation, what happens is that the width is higher, and then it's expected to be more than 0.6, as you said, and then moderate between less than 6 to 3, and then mild less than 3. So that's basically what I can actually say. I hope I'm right in what I've just said. So that's a little contribution I can say. Then again, too, I did not really understand the EPO. You said there are various parameters we can actually use to get the severity of aortic regurgitation. I don't know if you can explain to me how one can actually ascertain using EPO to get the severity of aortic valve regurgitation. So I don't know if you can help me out with that. Hello?
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 So, Dr. Alex, did you get her question? Thank you so much, Dr. Florence, for the beautiful contribution and your question. Dr. Alex, are you there?
I am, sir. It's actually
All right, I
about,
think.
you're asking about, hello?
Okay, you made mention of, I don't know if you can go back to the slide there where you had different, we actually have different parameters we can actually use in
Let me
measuring
quantify.
the severity of aortic regurgitation, where we have that of the regurgitant, the jet, I think the length of the jet or so, and then using vena contracta, using the fraction. Then there was a fourth one you mentioned, was it EPO or so? I don't know how that can actually be used. I know for the fraction, you can actually get get the area of the regurgitant jet, and then get the area of the left ventricle, and then what you get, you get the area of the what do you call it, the regurgitant jet divided by the area of the left ventricle times 10. I think that's how you get that of the fraction, the regurgitant fraction. But I don't know about, is it ERO also you mentioned? How do we get that? How do we measure that on echocardiography to know the severity of aortic regurgitation?
Okay, see ERO here. That is part of the method you use for quantitative measurements. So for quantitative measurements, you can either do a direct measurement of regurgitant volume or the fraction, like you mentioned, or you do the ERO. So is a PISA method. Okay. And then it can be calculated. The ERO is actually a function of one, the valve, that's the mitral regurgitation. It's actually a mathematical equation. I don't know if I can explain that further, but it's like what you use for the binary equation, but this time you're using 2 pi r square VA over V something of the mitral valve. Is actually is a way to measure temporal regurgitant leaks, okay, in a continuous wave Doppler. It's a formula. Let me look for it. Put it somewhere here, but it's a way to look at the ERO. Just simply means effective regurgitant orifice area. Because it's area, we are looking at pi r square, and then 2 into the velocity, the area, the velocity over the velocity of the mitral regurgitation.
All right. Okay. Thank you so much. Thank you.
2 times the pi r square is the area, velocity of the area, then the velocity of the mitral regurgitation.
Yeah, thank you so much, Dr. Alex. Sometimes it's quite difficult to explain some of these concepts on Zoom. Well, you've done quite a whole lot of justice to it. Thank you, Dr. Florence. Hello, Chief, sir. Prof wants to say something.
They know ERO here. Okay, so it's not about the formula. Nobody is going to solve with the formula. Okay, the formula is embedded in the machine. All right, but what you should know is what parameters you need to, because before you to write an echo report and say that this person has a severe AR or moderate AR, your effective regurgitant orifice area value should be written in that report. Okay, now I think the important thing you should know is the concept, then how you get it on your echo machine. All right, so what's the concept? So the concept simply means, look at the word effective regurgitant orifice area. So meaning that if there is a regurgitation, it's passing through an orifice, right? So what is that area? What is that orifice area? It is that orifice area that will tell you the severity of the regurgitation. If you have an orifice area of 0.1 or less than 1.1, it will tell you that the volume of regurgitation will be small, compared to an orifice area of more than 0.3 or 0.4. You will know that your regurgitant volume will be very high. So that is why if you notice from this slide, you will notice it's a quantitative measurement, and the regurgitant orifice area is what will determine your regurgitant fraction and your regurgitant volume. So if you go and see the formula very well, you will notice that the formula contains regurgitant volume and regurgitant fraction, because it is this orifice area that will tell you the volume of blood that is regurgitating back into the LV. I hope you get it, sir. So
Yes, bro.
the simple meaning is that a valve is meant to close and the regurgitant orifice area should be 0 if there's no regurgitation. So the larger the area that is not closing, the bigger the regurgitation. Hope you get that, sir.
Yes, sir. Thank you, Prof.
So that is why you cannot make an echo report without putting an ERO
Okay.
area inside. Number 2 is that how do you get it on your machine? It's straightforward on the machine. Most machines don't have it. They have it. Okay, so don't say my machine is old and it's not there. It's there. Go and check very well. So when you get your usually best measured in Plaques view. Okay, so in your Plaques view, you zoom into your LV outflow tract. Okay, then at mid diastole, okay, you take your measurement. You will have used the PISA. You click on the machine under PISA. All right. So when you take your color image of the LVOT, you click on measurements. All right. Under measurement, look for PISA. So you now see PISA for mitral, PISA for aortic, there's PISA for pulmonary, PISA for everything. Okay. So you click on PISA for aortic. Then you measure. So you would measure the diameter of the volume that regurgitates back. Okay. So your measurement is beyond the valve, not before the valve, because that's what's regurgitating back. Okay. So beyond the valve. So the volume that is coming in from the aorta into the LV. Okay. So you are measuring beyond the valve, not before the valve. So when you get that volume at mid diastole, it saves it. Then you would go to apical 5, do your continuous wave at apical 5. So you notice that regurgitation would have flow above the baseline, Abi, if you put continuous wave in. So instead of measuring pressure half time now, you're going to do a VTI. I'm sure we all know how to do VTI, velocity time integral. You are tracing the whole of the flow above the baseline in the continuity, in the continuous wave. So you're going to do a tracing. You are tracing the whole of that flow above, and it's going to show you the VTI, that's velocity time integral for the aortic. So the moment you have that true value, it will automatically calculate for you your EROA. It will automatically calculate your regurgitant volume and regurgitant fraction. So those are the only 2 things you need. It's very easy to do. So as I said, you click on the PISA, you get the PISA area. Okay, PISA area are the best seen at the Plaques view. When that is done, you go to apical 5, then do the VTI for the regurgitant gradient now on the continuous wave. You do a VTI, a full tracing of the gradient. So those 2 parameters are what you need to calculate the 3 parameters under quantitative methods or measurements.
Wow.
That is all you need.
Very
You'll be
much.
done. So very simple and easy to do.
Thank you very
Wow.
much. Wow.
Then there's one
Thank
comment
you
I
so
need to address under for Dr. Flores. You made a comment when he showed the slide on the art sound. So I think what you should rearrange in your comments is that, because the valve is stenosis, that's why you're not hearing the A2. Is not correct. You get the reason for P2 and A2 to be together in moderate is because of the prolongation of the ejection time in the LV. It's the valve is stenosis, so the ejection time for the LV is getting longer. It's meant to pump out also certain volume of blood, but because the valve area is small, so it's taking longer time to pump that volume of blood, right? So
Yes,
if the
sir.
ejection time is increased, that means that A2 will now be matching with P2. And that is why if you look at the same slide, under severe, you will find out that P2 is now paradoxical now. P2 is coming before A2. It tells you that the ejection time is now getting more and more prolonged. Yeah, you can quickly go back to, then keep this slide. We still go back to that color slide so that it's easy to calculate. So you can see here now, you will notice that in the severe, P2 is coming before A2. It's not because A2 valve is not, the sound is coming. The valve is still making the sound, but it's because the ejection time is getting longer. It's far longer than in moderate compared to mild also. Okay, so what determines P2 closing before A2 is simply the ejection time. The valve area is very narrowed, and now it's taking so long the time to pump out blood from the LV. The blood has to be pumped out. So that is why these heart sounds are happening this way. One important issue go and learn is carotid apical carotid delay. Apical carotid delay. So there's a concept called apical to carotid. That means that from the apex beat to the carotid pulse, there is a delay. And that delay is caused by the prolongation of the ejection time. It's one concept you should go and you should read something about.
Thank you, Prof.
One last thing is there was one slide you showed so that I could explain the EROA again. Before you go to this slide, there was one slide that had the color Doppler of, yeah, keep going, MIC. Yeah, under your echo. Yeah, can you go back a little? There was one continuous wave Doppler we saw now. Yes, you should click on that continuous wave Doppler. Yeah, so the next one. So when you can see this VTI, no, go to the next one. Next one. Yes, you can pull this up for us. So you can see the VTI. Now, so the only challenge here is that this VTI is facing down for AS, but in AR, we all know that the VTI, the regurgitation will be up, right?
Yes, sir.
Yeah, so you can see the way they traced it. So that's the meaning of the VTI tracing, velocity time integral. So you also trace it for regurgitation. If you are doing regurgitation, you will trace it like that above the baseline for regurgitation. So that will give you the regurgitant, that will be your VTI for the PISA. Okay, so if you now go to color, let's go to color now. For the regurgitation now, I think you need to go to aortic regurgitation. There's a place that showed the regurgitation. There was one slide you have. I think, yes. Good. So you can.
Sorry, sir. That VTI for PISA you just talked about, would that one be gotten on parasternal long axis? The one you just showed us now?
You only be seen in apical 5. You can only get
Okay,
VTI. Don't change this.
Okay.
Okay.
But you made mention of PISA under the parasternal long axis.
And that's what I want to
PISA
show
for
you.
aortic. Okay, sir.
And that's what I want to show you. Relax. That's what you show you. Can you see that this is Plaque's view, right? Yes or no?
Yes, sir.
Yeah. So you can see the PISA is trying to measure now. If you zoom well on your slide, you will notice that he had measured, even though he's trying to use it for vena contracta, jet width, it's also this is where you get the PISA area. Okay, so I want you to move, if you can also zoom on your screen. And so Dr. Itsubi.
Yes, sir.
I want you to use your arrow to do something for us. Yeah. So yeah, use your hand. You see that hand? Put it at the tip of the, yes, from the beginning of the color flow. Yes. To the vena contracta. Yeah, I want you to trace something for us. So it's like, yeah, from there to the vena contracta. Exactly. You see that diameter?
Yes, sir.
from the tip to, so we call it the head, the neck, and the body is the jet width. So from that head to the neck is the PISA area, okay, which you're going to supposed to get in mid-diastole, okay? That's the PISA area. So that is what, so when you click on your machine and you say PISA to do a PISA radius, so that is actually the PISA radius, okay? So immediately you get it, you save, as in, then you now go to apical 5. So that's the PISA area in plaques view, okay? So now you can go to the next slide now. Yes, good. So you can see this slide now. It's gotten, so this will be gotten in apical 5. So you can see this jet. So you can now do the, you can now see the VTI that is done. So even your VTI is going to give you your pressure half time and also show you the total VTI. So you can see the VTI now. You can use your hand to trace it for us. So the same way you trace. So that is the two you need. No, VTI for regurgitation is above, exactly. Exactly. Look at the first panel. It has already been traced in the first panel. You see that? That's the VTI tracing. So that's what you do. So those are the only two things you need to do. And that's what you will get. Is you give it your PISA volume, I'm sorry, your EROA, your regurgitant fraction, and regurgitant rate. So it's very easy to do. Very, very easy to do. Hope it's clear, sir.
Thank you very much, Prof. It's clear. Thank you, sir.
Thank you, sir.
very much,
Thank you,
Prof.
sir.
Thank you so much, Prof, for that elaborate contribution and explanation. Please, Dr. Itubi would need to go home. He actually did this presentation away from home, and we know the way the country. So please, if you have any contribution, can you please do it very fast before we call on our facilitators to give final contribution before closing? In no specific order, please, you can unmute your mic and speak fast, please. All right, so whose hand is up? Rukaya, please go ahead.
Okay, good evening, Prof. Good evening, colleagues, senior colleagues, and well done, Dr. Tubi, for the wonderful presentation. I just wanted to add, for risk factors of AS, that's stenosis, you did say that the most important risk factor was sclerosis, which progresses. Now, one of the novel risk factors for aortic sclerosis is lipoprotein little a, and it's been found to be strongly associated with AS, and it may explain why Blacks tend to have AS at a younger age than whites. You did mention most whites would be in their 70s. And although there's no treatment yet for lipoprotein little a, there are drugs under trial, and this may, have a role in AS in time to come. And we may recall that lipoprotein little a, the serum levels are highly variable, and the most important factor that determines serum level is genetics. And Blacks of all the races in the world compared to white, Caucasians, Asians, blah, blah, have the highest average levels. So just that. Thank you.
Thank you very much for this addition. Thank you.
Thank you so much. So we'll call on Dr. Kweki for input, contributions, and clarification before Prof. And then we'll close the class. Dr. Kweki, sir, you are there.
Yeah, thank you, Dr. Alex, for taking the time to put the slides together and be able to do the presentation in detail. I can imagine the energy and the time you put into that. Just one question I'd like to ask. How you're the cardiology, assuming that this is an OSCE exam, station 4, and you have a 70 years old gentleman who comes in severe aortic stenosis, and the report of the echo is before you, done by the cardiophysiologist, and the patient have severe aortic stenosis and meet criteria for surgery. Let's say that we've accepted the patient to go for surgical valvular intervention. So how will you prepare the patient for surgery? Or what are the things you will do? You're going to call the cardiothoracic surgeons that you got the patient like da. So what are the things you have to be sure they're in place, while the patient is being prepared for the surgery?
Okay, thank you, sir.
Yeah.
First, I think I would like to prepare the patient for surgery. One, okay, discussion with the patients, and then about their medications if they are on any. But what I would like to do before surgery for the patient is, one, to confirm that this aortic stenosis or the value the person has been given is appropriate for the person. Then I would like to now go ahead to look at comorbidities in this patient, if there are comorbidities in this patient that can affect outcome in surgery, because there are some contraindications to surgery, like being elderly, being frail, or having other comorbidities, and ensure that patient has good no focus for infection or any of that at the time. So if the patient is on any medication like ARBs or ACIs, the patient has to discontinue use of the medication before the surgery. And if the person is also on blood thinners or any of those medications, he has to stop before the onset, before surgery. That's what I can say for now, sir.
Okay, so that's fine. That's a good approach. One of the experience I had why I was doing some posting there in the backup is the fact that the surgeons usually want to be sure of the size of the valve. They want to be sure of the size of the prosthetic valve prior to surgery. So they need to have an idea of the diameter. So sometimes you need to be very sure of your echo parameter, even though cardiographers or cardiac physiologists will have done some of these measurements. It's usually reasonable for you to look at some of these images directly, or if you had done the echo, you need to be sure that all your measurements, including the LVOT diameters, the areas, and all those things are properly done. That's number one. Number two, most patients that are going for aortic valve replacement, you want to study their coronary anatomies. In other words, you like to do coronary angiogram for them. The reason why you have to do that is to find out if they have concomitant significant coronary artery disease. So you may as well just do both bypass surgery and replace the valve together, so that you don't replace the valve this year, and about 2 years later, the patient comes down with significant coronary artery disease, such that the patient now require bypass surgery. Remember, you have to do stenotomy to have access to the heart. So that may be difficult. So most time, part of the workup for surgery is for the patient to have a coronary angiography done, just to have an idea of the coronary anatomies to see if it's significant for bypass surgery. So you may as well just do the two together.
Wow.
Then part of the workup is to do your coronary artery, carotid artery Doppler.
Okay.
Again, still similar reason because you love to do that because you want to be sure that this patient does not have significant
Aortic
carotid
stenosis.
stenosis. Remember that these are all vasculopathy. So
Mm.
whatever is going on in the aortic valve may as well be affecting every other valve in the system. So patient may just have significant cardiac stenosis. Again, you may want to do that together. Okay, stage the procedure. Sometimes you may just want to finish up with the carotid artery atherectomy, then you move to the valvular replacement, or if it's not so significant, you can do them at different times depending on the decision of the surgeons and those that are involved. So that's what you do. You will still go ahead and do oral check. You need to check the denture of the patients in case the patient have any dental caries, because you don't want to stock in a prosthetic valve and patient comes down with prosthetic valve infective endocarditis because of dental caries that wasn't sorted out. So you need to check the oral cavity and be sure that the patient does not have any dental abscess, dental caries, and all that. So if they have dental abscess, you might as well just address it before you replace the valve, because we all know that that's a risk factor for prosthetic valve infective endocarditis. And of course, we know that prosthetic valve infective endocarditis has a high morbidity and mortality, and the risk of reduced surgery is very high. So you want to sort that out too. Then, apart from that, of course, don't forget the question. Usually, don't forget the usual blood, the routine blood that we do, anemia, the kidneys and all that, to be sure that comorbidities are not a major impact here in the patient. And again, it's always good to have a very detailed discussion with the patient. In fact, it's where things are working. You supply them with pamphlets and mainly books where they have to read the whole procedure, including what will happen pre-op, intra-op, and post-op, and how they will recover, how many days it will take them to recover, how they will get back, and then the issues of driving. Where things are working, you have to tell them they can't drive for about 4 weeks or thereabout. So these are some of the things you put in place in this group of patients. But if the patients are going to be doing TAVI or TAVA, if you're following America or British will say TAVI, Americans will say TAVA, BTAVA, any of them. So it's another ball game also, because you want to carefully select your patient. Like you have said, I saw the algorithm that you put forward where you have to select whether you want to do an open heart surgery or you want to do TAVI. It's important for you to really pick your patient, because if you don't pick your patient, the success is very low. That's why they talk about the concept of TAVI assessment. So before a patient goes for TAVI approach of valvular replacement, you need to assess the patient. And one of the things you have to do is to do CT assessment of the root of aorta. Is very important. The CT assessment of the root of aorta is beyond looking at not just the aorta anyway, but including the femoral arteries and arteries, because you're going to deploy the valve through the femoral root. And again, the femoral sheets that we usually use are bigger. You know, the usual catheterization in cath lab, we use about I think it's 6 or 7 French also. But once you're going to do TAVI, you use up to 12, very big. So you need the femoral vasculation of the patient to be very good. You don't want the patient to have a lot of calcifications and all that, such that you're not able to, pass your catheter. So CT assessment of the vasculation of the patient is very important, including the femoral artery, the size of the aortic root, and you must carefully measure the distance of the annulus of the aorta to the branches of the coronary arteries, because you don't want to deploy TAVI that will occlude the branches of the coronaries, so which will be a problem. So you have to carefully measure the diameter and the distance for you to be able to deploy the TAVI valve correctly. So these usually patient will go for this assessment where the surgeons will have to sit down, look at all the parameters, do the assessment and all that, see if patient is favorable. So you have to ideally select the patient, which is also part of the workup for surgery. So in essence, I'm just trying to say that it appears that it is the work of the cardiologist to work up patient for surgery. Again, the patient comes to you, and once the patient comes to you, you have to do that. Don't forget that if the patient presents in heart failure, you have to offload the patient and ensure that patient is out of acute heart failure before you start thinking of surgical intervention. Many things to say, but I understand that the time is running, so I will not keep the time further. This should be more than 11 o'clock over there. So for now, I will just stop here. Thank you so much.
Thank you so much, Dr. Kweki, for very applicable knowledge. That's one beautiful thing that we're getting to learn these days. Thank you so much, sir. We'll call on Prof if he's still available for further contribution. And
Professor, don't let me delay. I think Dr. Kweki has given us a good cap. As he said, assessing the coronaries, assessing the carotid, assessing other valves wants to make you do a holistic management for these patients, especially when they are going into the surgery. Most surgeons don't want to do a redo surgery. So it simply means that anything they need to do once on the patient, and that's why you see it in the guideline. When a patient should do a valve replacement if he's going for so other surgery like a bypass and things like that. So that means that the physician or the cardiologist should have assessed for every other conditions that would be treated during that first pass surgery. It's clearly written in the guideline. Secondly, is that why should a patient with severe AS likely have coronary artery disease? Because the atherosclerotic process that is happening in the aortic valve is also happening in the coronaries in the carotid. That has been well explained by Dr. Kweki. So all these things so if they are asking the exam, these are things you're supposed to mention in management of these patients. Thank you very much.
Thank you so much, sir. Thank you again, Chief Kweki, for bringing application to a lot of this our knowledge base. Thank you so much. I think that's all for now. Dr. Adeyanju, over to you. Thank you.
Thank you so much, Charles. It has been a great learning session tonight, Prof. We are so grateful, sir, that you are here with us and that you've clarified things for us. We'll go back and just look through the slides that Dr. Itubi has given us. Thank you, Chief Kweki. Thank you, Dr. Okopi, for always being there for us. It has been a great learning session. Dr. Itubi, we are very, very grateful. we know you have to go home now because it's late, but we are very, very grateful. We'll go through the slides. Thank you,
so much
sir.
for the privilege. Prof, sir, I'm very grateful. Thank you, Dr. Kwokpi. Thank you, everyone. Thank you so much. Thank you.
Yes, sir. So with the humble permission of our consultants and trainers and our chief there, I don't know if this is the right time to just bring the class to a close, sir, so that we'll all meet tomorrow, sir. Chief Okopi.
That's fair enough. So meet tomorrow. Thank you so much, Kweki, for coming. Actually, Kweki has been very engaged and he's coming here. It's a big blessing. Thank you for finding time to come out today.
Thank you,
Thank
sir.
you again.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, Prof. So we'll meet tomorrow then.
Yes, sir. Thank you, everyone. Good night.